Starting 3, 2, 1, go.
Who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Jyoti Bajaj Sahani, all discussants and participants to this virtual symposium on CMML and other monocytic malignancies, challenges in diagnosis. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the edges of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit is a passionate clinician and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Madan, for that kind introduction. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Jyoti Bajaj Sahani from Ahmedabad. She's going to lecture us today on CMML and other monocytic malignancies, challenges in diagnosis. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus Dedicated to Life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Jyoti Bajaj Sahani from Ahmedabad, all our discussants who are themselves eminent hematologists and hematopathologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 25th June 2023, we have a webinar on mass spectrometry for multiple myeloma from 11:30 a.m. onwards by Dr. Hannah V. Giles from Birmingham, UK. Let me introduce our discussions for the day, here displayed in alphabetical order. To start with, we have Dr. Akshay Mandloy from TMH HBCH Varanasi, Dr. Ankur Ahuja from AFMC Pune, Dr. Deepak MB from MSMC Narayan Health City, Bengaluru, Dr. Geeta Vidyadharan from Karkinos Laboratory, Kochi, Dr. Kunal Goyal from Tata Memorial Hospital, Varanasi, Dr. Mohammad Taha Ali Khan from NIMS, Hyderabad, Dr. Myat Malleshwe from Mandle, Myanmar, Dr. Nailesh Shah from NHL Municipal Medical College, Ellis Bridge, Ahmedabad, Dr. Parimal Sharda from Uniped Specialty Laboratory Limited, Ahmedabad, Dr. Rupam Deka from AIMS, Guwahati, Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida, Dr. Swati Sinha from King George Medical University, Lucknow, Dr. T. Ramadevi from Gujarat Cancer Research Institute, Ahmedabad, Brigadier Dr. Tathagat Chatterjee from Faridabad, Haryana, and Dr. Umang Patel from Green Cross Genetics Lab, Ahmedabad. Now it's a time to introduce our guest speaker for the day, Dr. Jyoti Bajaj Sahani from Ahmedabad. Dr. Jyoti Bajaj Sahani is DM Hematopathology, Assistant Professor in Oncopathology at Gujarat Cancer and Research Institute, Ahmedabad. She has done her graduation from Bharati Vidyaput, Pune from the year 1995 to 1996 and post-graduation in MD Pathology training from Armed Force Medical College in the year 2000. She has worked as a senior resident in the Department of Hematology at AIMS, New Delhi in the year 2004. She did her DM in hematopathology under the guidance of Dr. V.P. Chaudhary and Dr. Renu Saxena at All India Institute of Medical Sciences, New Delhi in the year 2005 to 2007. She joined as junior lecturer in Gujarat Cancer and Research Institute, Ahmedabad in the year 2009 and is currently working as assistant professor in Department of Oncopathology till date. She has vast experience in teaching MD pathology students and currently is PG teacher and training DM oncopathology residents in hematopathology. She has published research work in papers, undertaken projects related to PNH and ALL, and has delivered several talks in national and international meetings. She is going to lecture us today on CMML and other monocytic malignancies, challenges in diagnosis. Well, thank you so much. Over to you, ma'am.
स्क्रीन शेयर स्क्रीन में कौन सा वाला चलाऊं? आजकल कुछ और शेयर करें. Sir, we are just trying to make the screen
No issues, ma'am.
ये outline वाला कर देते हैं. हाँ.
Perfect.
Right. Am I audible?
Yes, ma'am.
Thank you, Dr. Khurana, for this warm welcome. And I am very thankful to Mumbai Hematology Group for giving me a chance to present in front of them. And I also thank the expert panelists today for sparing their time on a Saturday evening to listen to this lecture. And I hope I live up to the expectations of all those who are going to listen to me today. The outline of my talk is introduction. Then I will be talking about acute monocytic leukemias. Then on chronic myelomonocytic leukemia. Then juvenile myelomonocytic leukemia. And finally, I will conclude the topic. As we all know, the monocytes in the human beings have n number of functions. In the tissues, they function as macrophages, where they are associated with phagocytosis. They also function as dendritic cells that are involved in antigen presentation. They have two receptors, CD14, which is also called the lipopolysaccharide receptor, which is involved in phagocytosis. Another receptor called Fc gamma receptor, which is also called CD16, that is involved in the regulation of inflammatory response. In addition, monocytes is involved in interactions with the coagulation system, and to some extent, it has a role in wound healing. Now, the stages of maturation of the monocytes include the following: the monoblast, the promonocyte, the immature monocyte, and the mature monocyte. It is important to differentiate the different stages because acute leukemias predominantly are involve the monoblast and the promonocytes, where the promonocytes are also equivalent to blasts, whereas the chronic malignancies generally involve the mature monocytic cells. So let me describe how these monoblasts, how do they appear on the peripheral smear? The monoblasts are have a round to oval nucleus. They have a delicate chromatin. The nucleolus is prominent. Their cytoplasm is basophilic. They do not have any azurophilic granules, and they are large cells around 20 to 30 micron. The promonocytes have a slightly convoluted nucleus. They also have a delicate and chromatin, and a nucleolus is prominent. They are variably basophilic, have variably azurophilic granules, and except for the nuclear shape, they are very similar to monoblasts. The immature monocyte have convoluted or indented nuclei. They have a more condensed nucleus. Nucleoli are generally not seen in these cells. They are less basophilic than promonocyte or the blasts, but are more basophilic than the mature monocyte. And the monocytes, as you can see to the extreme left, are cells that are lobulated. The nuclear is extremely lobulated. The nuclear chromatin is condensed. There is no visible nucleolus, and they have they have a gray cytoplasm, occasional azurophilic granules, and may also be vacuolated. Now, in this study that was undertaken to see concordance amongst hematopathologists in classifying blast plus pro-monocytes, a bone marrow pathology study group, 11 expert hematopathologists were given cases of AMML, acute monocytic leukemias, as well as cases of CMML to see concordance amongst them in identifying these cells. In the figure over here, the two cells on either side are the monoblasts. The one on the 6 o'clock position is the pro-monocyte, and on 12 o'clock position is the monocyte, mature monocyte. It was seen that when the 11 hematopathologists were blindfolded for the diagnosis, the concordance for blasts, monoblasts, and pro-monocytes together was very high. However, the concordance for immature monocyte and mature monocyte was not there. Also, it was seen that these pathologists were able to identify blast plus pro-monocytes with high degree of accuracy in the peripheral blood. However, there was no concordance or a low concordance among them when the same cells were identified in the bone marrow. So this is very much like what we see over here. And we also, while seeing the peripheral smear, very confidently can identify the monoblasts because they have large cells, abundant cytoplasm, round nucleus, prominent nucleoli. Pro-monocytes and immature monocytes, sometimes we have a difficulty in identifying between them. And so our concordance is also more for blasts and pro-monos, but immature monos and mature monos are confusing, while we are also seeing the peripheral smear like it was in this study. Now, here they have concluded that whenever there is a difference in the blast count between peripheral smear and bone marrow, and you want to do a risk stratification for the acute leukemia or chronic leukemia, and you're getting a discrepancy between blast count in the peripheral blood and bone marrow, since this study shows that the concordance amongst experienced hematopathologists is more in the peripheral blood than in the marrow, and if your blast count and pro-monocyte count, a blast plus pro-monocyte count in the peripheral blood is higher than that in the marrow, then one should go for the counts that are being given in the peripheral blood. Now, what are the causes of peripheral monocytosis? Neutropenia and bone marrow recovery can cause peripheral blood monocytosis, chronic infections, immune inflammatory disorders, myocardial infarction, sickle cell disease, chronic stress, post-splenectomy, iatrogenic causes like cytokine therapy, steroids, radiation therapy, along with some malignancies like cutaneous myeloid dendritic cell dysplasia, myeloid malignancies like MPN, MDS, MDS-MPN, and AML. Lymphoid and plasma cell malignancies can also cause monocytosis and solid tumors like carcinomas. Now, coming to today's topic, where I will be talking on neoplastic monocytosis, is seen in two conditions: the acute neoplasms, and includes mainly the acute monocytic and myelomonocytic leukemia. And in chronic neoplasms, I will be talking on chronic myelomonocytic leukemia and juvenile myelomonocytic leukemia. However, there are other causes for monocytosis in chronic neoplasms, which include myeloid neoplasms with PDGFR beta rearrangement that can very much mimic the CMML, myeloid neoplasms with PDGFR alpha rearrangement, myeloid neoplasms with FGFR1 rearrangement, PCM JAK2 fusion, CML, where the transcript is P190. And here, even if you're getting a Philadelphia chromosome negative on FISH analysis, it is recommended to do RT-PCR to look for the P190 transcript. And myeloproliferative neoplasms with monocytosis includes all these Philadelphia negative MPNs like ET, polycythemia, primary myelofibrosis. Systemic mastocytosis can be associated with monocytosis, B and T cell malignancies, and solid tumors. Now, coming to acute monocytic leukemias, like we know, there are two acute myeloid leukemias that are associated with monocytosis. First is the acute myelomonocytic leukemia, where the diagnosis is made by more than or equal to 20% monocytes and their precursors in the peripheral blood and marrow, more than or equal to 20% maturing granulocytic cells, and more than 3% or more than or equal to 3% blasts positive for MPO by immunophenotyping or cytochemistry. Then we have the acute monocytic leukemias, where more than 80% of the monocytes and their are monocytes and their precursors, where the blast count includes both monoblasts and pro-monocytes. Less than 20% are maturing granulocytic cells, and these blast and pro-monocytes can be identified by at least 2 monocytic markers, which include CD11C, 14, CD36, and CD64, or NSE positivity on cytochemistry. Now, this is a photomicrograph of acute leukemia, and you can see that there are peripheral smear is infiltrated by plenty of blasts. Now, from what I can see in the first slide is that these blasts are huge. They have basophilic cytoplasm, open nucleochromatin, and prominent nucleoli. I first come to the conclusion that these are first come to the diagnosis that this is possibly a myeloblastic leukemia because of the open chromatin of the nucleoli. And since these are large cells, diagnosis of monoblastic will definitely come into my mind. However, sometimes these same blasts can appear a little different, and then a differential diagnosis could include cases of a myeloblastic leukemia, a myeloblast, or like AML M1, or even sometimes we consider lymphoblast L2 types. But these are the differential diagnoses which will come in my mind for the first case. But since my first impression is myeloblastic, I feel these are monoblasts. Coming to the second slide, this slide is also having blasts, but here there is some amount of nuclear indentation. Now, a DD of in this case could be pro-monocytic leukemia, where the acute monocytic leukemia with predominantly monocytes, but a differential of acute promyelocytic hypogranular variant of acute promyelocytic leukemia can also be thought of. So, when we have these kind of differentials in the peripheral blood and bone marrow, we proceed ahead with cytochemistry. And if it is SB and MPO positive, we classify them as MPO, as myeloid leukemia. But sometimes in these leukemias of monocytic lineage, the SB or MPO stain is weak or negative, and then we submit the case for flow cytometry. Now, this is a Euroflow consortium panel for identifying myeloid leukemias, and in this panel, they have 7 tubes to identify the different lineages in acute myeloid leukemia. And like you can see, all the tubes will have backbone markers for identifying blasts, which are HLA-DR, CD34, CD117, and CD45. Apart from this, the different tubes will have markers for identifying different lineages of the myeloid cells, where tube number 2 is basically having markers to identify monocytic cells, which monocytic leukemias, and the markers used in this tube for identifying the monocytic lineage are CD35, CD64, tube number 2, CD35, CD64, CD300E, which is also called IREM2, and CD14. Now, before we proceed to look for anything abnormal or to see where the leukemia has whether an maturation arrest, at what stage has a leukemia undergone maturation arrest or is showing aberrant expression, I would like to talk about how the expression of these markers takes place in the normal monocytic maturation. As you can see in graph A, the immature cells are blue and red in color, which are the monoblasts. They express increased amount of CD64, but are negative for CD14. However, as they proceed to become pro-monocytes and mature monocytes, they begin to express CD14 along with CD64. In the graph B, you can see that the markers used are CD117 and CD34. Again, the blue dots, which are the monoblasts, are showing CD34 and CD117. However, as they proceed from the monoblastic stage to the pro-monocytic and monocytic stage, there is downregulation of CD117. This is which is in contrast to what happens when granulocytic series proceeds from pro-myelocyte stage, where there is no downregulation of CD117. Coming to graph C, you can see that all the 3 lineages are showing expression of HLA-DR. In the graph D, the blasts, as they proceed from pro-monocytes to the mature monocytes, which are yellow in color over here, they will show increased expression of not only CD14, but also CD35. And graph E, the mature monocytes will show increased expression of CD14 and CD300E. So, monoblasts show predominantly CD64, and as they proceed from monoblastic stage to pro-monocytes, there is downregulation of CD117, and gradually they begin to acquire CD14, and the mature monocytes will acquire CD35 and CD300E in the mature monocytes. So this is one case which has come 2 days back in our lab, and on morphology we were thinking of it to be acute monoblastic leukemia. We sent it for IPT, and this is by the backbone markers CD45 dim population. In the blue dots are the dim population. This was CD34 negative. However, it was showing MPO positivity. The first tube is for lineage assignment. So cytoplasmic CD3 was negative, but MPO was coming. On further analysis, the blasts were CD117 positive, CD13 positive, dual expression. They were HLA-DR positive. However, there was no expression of CD14. And the last tube was showing CD33, bright, and CD64. Based on this expression of CD64 and absence of CD14, we confirmed the diagnosis to be acute monoblastic leukemia. This is in another case that had come the same day. Here again, the CD45 gating is P3 population. The blue dots are CD45 dim, which is a way to identify the blast. Then, when we proceeded to see this, these blasts were CD34 positive. They were expressing MPO. CD117 was present, CD13 was present, HLA-DR was present, CD14 was present, 33 and 15 were expressed. Since CD14 was present, we did not go ahead with CD64. Generally, we asked for CD64. And based on the fact that this was expressing CD14, we made the diagnosis of acute monocytic leukemia, probably showing more of pro-monocytes. We do not have CD30, 300 and CD35 in our panel, but when they are present and if they come positive, then for sure this leukemia is acute myeloid leukemia with monocytic differentiation. Coming to the next entity, chronic myeloid neoplasms, and here the prototype over here is chronic myelomonocytic leukemia. Now this is a disease which has overlapping features with MDS, where the patients in their marrow can in their blood and marrow can show cytopenias and dysplasia, and they have differentiation defects, as well as these same patients who have this disease can also show features of myeloproliferation, constitutional symptoms, splenomegaly, fibrosis, and JAK-STAT activation. So chronic myelomonocytic leukemia is the most frequent of the MDS-MPN type, with 4 cases per 100,000 persons. The median age is 75 years with slight male predominance and is characterized by pathologic myeloproliferation of granulocytic and monocytic cells with coexisting evidence of myelodysplasia. This is a peripheral smear and bone marrow in CMML, where you will get increased number of monocytes in the peripheral smear. They are mainly immature and mature ones. The bone marrow is hypercellular. It will show here in this photograph, the bone marrow is showing erythroid dysplasia with normoblast showing hypersegmentation. Then you have monocytic cells. Megakaryocytes are appearing hypolobated and draw forms. And the biopsy is hypercellular with both granulocytic and monocytic proliferation. Sometimes it is difficult to differentiate between the monocytic cells and myeloid precursors, and in this case, it is the CD14 IHC is helpful in identifying the monocytic cells. So the WHO has now classified these cases, defined CMML as. The change that has happened from the 4th edition is that they got down the count of absolute monocytosis to greater than or equal to 0.5, which was previously 1 into 10⁹ per liter, and relative monocytosis in the peripheral smear of greater than or equal to 10%. This is an essential prerequisite criteria, along with blasts that constitute less than 20% of cells in the peripheral blood and marrow, not meeting diagnostic criteria for CMML and other myeloproliferative neoplasms, and not meeting diagnostic criteria for myeloid lymphoid neoplasm with tyrosine kinase fusions. Requirement for diagnosis is that if there is monocytosis which is greater than or equal to 1 into 10⁹ per liter, one or more of the supporting criteria must be met. And if monocytosis is 0.5 and less than 1, then supporting criteria 1 and 2 must be met. So what are the supporting criteria? These supporting criteria are dysplasia involving equal to or more than one myeloid lineage, acquired clonal cytogenetic or molecular abnormality, and abnormal partitioning of peripheral blood monocyte subsets. The ICC criteria is by and large the same where again it has, in agreement with WHO, the monocytosis, absolute monocyte count is defined as monocytes greater than or equal to 0.5 in 10 raised to power 9 per liter, and greater than or equal to 10% of monocytes in the blood cells, in the WBCs. Here it says that in case there is no evidence of clonality, then monocyte should be more than 1 and increase blasts and including promonocytes or morphological dysplasia. Bone marrow assessment is very essential in patients with CMML because when you get a case of CMML in the peripheral blood sphere may have less blast than in the bone marrow, and bone marrow will therefore help in identifying, classifying these cases. And sometimes the blasts may be quite increased in number, so that it may be thought showing suggestive of AML. Sometimes the diagnosis you may be getting peripheral blood monocytosis, but when you do a bone marrow, you feel that these were what were looking as monocytes, immature monocytes in the peripheral blood, and we were thinking of CML is actually AML with monocytic differentiation when you look at the marrow. So the diagnosis will change when you see the marrow, and hence the importance of doing a marrow. Monocytic proliferation may sometimes be more pronounced in the bone marrow than the peripheral blood, and this entity is called marrow predominant CMML. Bone marrow biopsy and aspirate are also essential to exclude CMML mimics. Sometimes you may get monocytosis with eosinophilia, which is more predominant in the bone marrow aspirate and biopsy, and also to confirm a diagnosis of oligomonocytic leukemia, which I will cover in the coming slides. CMML variants and differential diagnosis. Now, this is a case of CML. This is a case which looked like CML, but when we saw in the bone marrow biopsy, there were increased number of eosinophils, and this led us to do a PDGFR beta rearrangement, which came positive. The C is showing presence of mast cells, which are positive for tryptase. Thus, whenever you are thinking of making a diagnosis of CML, one has to keep its molecular mimics in mind. And these are the different, of which the most important one is the one that is associated with translocation 512 and with PDGFR rearrangements. This can be picked up by karyotypic analysis and is the one that very closely mimics CMML, but is actually a PDGFR beta rearrangement, which is a tyrosine kinase and responds well to imatinib. CMML with fibrosis can raise a differential between whether the case, when it has fibrosis in the bone marrow aspirate in the biopsy, sometimes it raises a differential between myelofibrosis. In this case, the bone marrow biopsy of CMML will show small dysplastic megakaryocytes scattered throughout the section, in contrast to a biopsy of primary myelofibrosis, where you will get pleomorphic and bizarre looking megakaryocytes. There is presence of megakaryocytic clustering, abnormal localization of megakaryocytes to the paratrabecular location, and in this particular, and a reticulin stain, which will show the fibrosis. And if in this particular case, a JAK2 was positive, here I want to emphasize in patients with CMML with fibrosis, you can get JAK2 V617 positivity, and this is a CMML that has more tendency to have a proliferative potential. And when confused whether this is JAK2 can also be seen in Philadelphia negative MPNs like myelofibrosis. In this case, the JAK2 allelic burden can be looked into to see whether this is whether it is primary myelofibrosis or CMML with JAK2 V617F, because JAK2 V617 allelic burden, if it is very high, it goes in favor of myelofibrosis, in contrast to CMML, where if it is present, the allele burden is on the lower side, like here it is 11, and then we can make a diagnosis of CMML with JAK2 V617F mutation. In addition, CMML cases in 20% of the times in the biopsy will show certain round of monomorphic cells, which are nothing but which are nodules of mature plasma cytoid dendritic cells. And to those who are not aware of this, may mistake this as a proliferation of blasts or probably a case of CMML that is progressing to leukemia. These mature plasma cytoid dendritic cells can be correctly identified by IHC by doing immunostains for CD123 or CD303. In addition, CMML can show presence of mast cells. When these mast cells are present in spindle shapes and in aggregates, like in this case, a mutation was D617V positive. This case was a case of systemic mastocytosis, and systemic mastocytosis is one of the malignancy which is very commonly seen in association with CMML. If these aggregates were not classically, if the mast cells were not fulfilling the criteria of systemic mastocytosis as a disorder, then we can give it as CMML with mast cells. But this particular case was having the D6816V mutation and was therefore a case of systemic mastocytosis and associated CMML. Role of flow cytometry in CMML has been documented in the current WHO classification. And how does this help in diagnosing CMML? This study by Silmogo-Butte showed that by using two markers, CD14 and CD16, it was possible to identify 3 types of monocytes in the peripheral blood of a healthy individual. M0 or the classical M01 or the classical monocytes, which are 77.3% in the healthy individual. Intermediate, and these are CD14 and these are CD14 positive, CD16 negative. Then M02 is approximately 9% in healthy individuals. These are called intermediate types and are both CD14 and 16 positive. And the M03 types, which are approximately 13.4 and are CD14 negative and CD16 positive. Now, what happens in CMML? They have shown that when they compared cases with different monocytosis in healthy blood donors, age-matched controls, non-CMML cases with monocytosis, reactive monocytosis, and CMML, they found that in the third figure in CMML, they found that there was a predominance of M01 monocytes in patients with CMML. And this was very different from the other graphs that you're seeing, where you will get some amount of intermediate and non-classical monocytes. So they defined that to identify CMML, M01 percentage greater than 94% has a very high specificity of 94% and sensitivity of 91% in identifying patients with CMML. In addition, aberrant expression of CD56, decreased HLA-DR, and aberrant CD2 are also other ways of seeing dysplastic or atypical monocytes in patients with CMML. In another study, they wanted to validate the monocyte subset analysis to accurately distinguish CMML from MDS that is associated and they found that it is associated with a favorable MDS prognosis. In this study, the receiver operative curve was done for cases of CMML versus reactive monocytosis and CMML versus MDS, and they took a cutoff of 94% M01 monocytes and found that this cutoff was highly sensitive for differentiating CMML from reactive monocytosis as well as from MDS. On further analysis of MDS cases with the presence of classical monocytes and absence of classical monocytes, they found that in patients with classical MDS patients with increased classical monocytosis, there was increase in AMC, there was a increase of WBC counts, and in the absence of classical monocytes, the MDS cases were associated with poor prognosis. So presence of monocytosis in MDS was associated with a favorable prognosis. Coming to special variants of CMML, the oligomonocytic chronic myelomonocytic leukemia shows increased monocytes, but no absolute monocytosis in the peripheral blood. These cases are likely classified when they were seen and were not fulfilling the previous criteria of more than 1 × 10⁹ per liter, were classified as MDS or MDS MP and unclassifiable. However, now when the WHO has lowered the count to 0.5, these cases are now being included as CMML. And the reason for this was that the study on these cases, it was found that on peripheral smear and bone marrow, it resembled very much like the classical CMML. In addition to it, it had the same mutational profile like that seen in CMML, like the TEC2 mutation, the ZRSF2 mutation, and the ASXL1 mutations. And therefore, in future, these cases needed follow-up because they could behave like CMML. In addition, the ICC also shows a table. ICC criteria talks about diagnostic criteria for clonal monocytosis of undetermined significance, and they have defined this as persistent monocytosis defined as monocytes greater than 0.5 and greater than 10% of the WBCs, and absence of presence of cytopenia, presence of at least one myeloid neoplasm associated mutation of a variant allele frequency of greater than equal to 2%, no significant dysplasia, no criteria for a myeloid or other hematopoietic neoplasm, and no reactive condition that could explain monocytosis when it is detected. The CMML classification in the current WHO is as follows. The WHO and ICC have categorized the CMML into two types, CMML 1 and 2, where in CMML 1 there are less than 5% blasts in the peripheral blood and less than 10% in the bone marrow, and CMML 2, where the blast count is 5 to 19% in the peripheral blood and 10 to 19% in the bone marrow. It has retained the previous classification of CMML as myeloproliferative CMML, when your TLC is greater than or equal to 13, and MDS CMML when the count is less than 13. And the reason for this is that they have seen significant differences between the two types of MDS and MP CMML, which firstly is different in terms of TLCs. There is high TLC in the myeloproliferative type of CMML. Then the immature myeloid precursors are seen to be statistically significant, where there are more in the peripheral blood, you get more immature myeloid precursors in the myeloproliferative type of CMML. The LDH is very high in the myeloproliferative type. They are in all the risk scores, the myeloproliferative type shows high risks categorization, and they have RAS mutations, which is statistically significant. Also, the death rate and survival time is also statistically significant. As is apparent in this graph, where it is seen that the survival of the myeloproliferative CMML is worse than that of MDS type of CMML, and they have a worse prognosis than the MDS CMML type. Now, coming to categorization, outcome comparisons on basis of CMML 1 and 2, which was the criteria in WHO 2008, and that changed to CMML 0, 1 and 2 in WHO 2017. It was found by a study by Dr. Logavi that there was no difference in the survival curves and between CMML 0 and 1. And basically, there were a few high-risk cytogenetics that were seen in CMML 1 were also seen in CMML 0. As a result, CMML 0 behaved very much like CMML 1, and so the current classification has done away with CMML 0, and therefore it has retained CMML 1 and 2. Now the current WHO classification, the 5th edition, has done away with CMML 0. Genetic alterations are needed to prove clonality in CMML to show that these monocytes are clonal, and these are the various karyotypes that can be seen. Favorable risk is associated with diploid karyotype and deletion Y. Poor outcome is associated with trisomy 8, alterations of chromosome 7 and complex karyotype, and intermediate risk will include all the other karyotypes. But now it has been seen that there is significant genetic homogeneity of CMML relative to other cancers, where it has been seen that both in JMML and in CMML, the number of mutations per coding sequence of the exon range from 0 to 25, which is much less than that which is seen in CLL, where you can get around 50 mutations per coding sequence, or you can get more than 100 in cases of melanoma. So there is quite the number of mutations seen in CMML are quite homogeneous, and very few mutations are repeatedly detected in patients with CMML. The most common mutational profiles in CMML include the epigenetic regulators, TET2 seen in patients, 60% of the patients, spliceosome mutations, SRSF2 in 50% patients, and another epigenetic modifier, ASXL1 in 40% of these CMML cases. The presence of SRSF2 mutation with mutated TET2 strongly correlates with the CMML phenotype. Thus, the epigenetic modifiers include TET2 and AXXL1, commonly seen in MD type of CMML. The myeloproliferative type of CMML more often shows signaling pathway mutations like NRAS, KRAS, PTAPN11, JAK2, And then the other mutation which is commonly seen is the spliceosome mutation SRSF2, which is seen in around 50% of the patients. In one study, they did next generation sequencing to see all cases that were referred to a hospital with peripheral blood or bone marrow monocytosis, and then these cases were first diagnosed on basis of morphology according to the WHO 2008 criteria. Based on this criteria, they were able to classify all cases of peripheral blood or bone marrow monocytosis into two categories: diagnostic and non-diagnostic. In the diagnostic patients of 142, CMML was seen in 114 patients. However, in non-diagnostic patients, they could not come to any conclusion. And when a repeat marrow was done, in some cases, they could again classify it as CMML. When they studied the mutational patterns in both the diagnostic and non-diagnostic cases, they found that the mutations were very much in patients with monocytosis, unexplained monocytosis for a long time. The mutational pattern was in the non-diagnostic cases was very similar to that found in the diagnostic cases, with presence of TET2, SRSF2, ASXL1, and NRAS. And even the non-diagnostic samples, like you can see, there are number of mutations on the right side. Most of the CMML patients will have 1, 2, 3, or 4, or more than 5 mutations. In non-diagnostic samples, also there were cases with 2, 3, or 4 mutations seen. And hence they felt that the non-diagnostic patients where you were not able to diagnose them as CMML on bone marrow morphology, the mutational pattern was very much similar to that seen in diagnostic CMML. When they analyzed the survival, they found that in the non-diagnostic and diagnostic, there was poor prognosis in cases with mutated samples on the right. They behaved CMML patients and non-diagnostic mutated patients, even if they had a single somatic mutation, were behaving as badly as CMML. Hence, they came to the conclusion that these patients that are having unexplained monocytosis for a long time can be sequenced by targeted sequencing. And if you detect mutations, even if it is one, they have one mutation, it is associated with bad prognosis. And these patients should be kept on follow-up. Also, one has to keep in mind the type of mutation that you're getting, because if the mutation is very much like the ones that you get in CMML, they behave like CMML. And one must also keep in mind that since these patients are elderly patients, there are chances of getting mutations due to age-related clonal hematopoiesis. In this case, like AXL1, DNMT3A, these are mutations that are associated with age-related clonal hematopoiesis. In these, if you are getting these kind of mutations, then you look for variant allele frequency. And if the variant allele frequency is less than 10%, chances are that this is a CHIP mutation. But if the variant allele frequency of CMML-like mutations or any other mutation is high, around 20 to 30%, then the chances are that these cases will in future behave like CMML and need follow-up. Thus, when we are saying monocytosis, we have a number of things to think about. Whether it is reactive monocytosis, have they given, is there any infection? Have they given GM-CSF, steroids? Or is it a monocytosis with undetermined significance? Or is it clonal? If it is clonal, is it CMML? If it is CMML, whether it is like the MDS type, multilinear dysplasia, or if it is having like 5 to 10% blast, is it an oligomonocytic CMML or MDS EB1 type? CMML2 dysplastic will look like MDS EB2. Proliferative will resemble an MPN. If again, if it is history is acute, you have to keep in mind that the monocytosis could be because of could be due to acute myelomonocytic leukemia. And if you get a RAS mutation, then you have to keep in mind that is this monocytosis due to juvenile myelomonocytic leukemia. Coming to the last part, the juvenile myelomonocytic leukemia. This is these are generally patients, small children whose age is generally less than 2 years. Generally, this disease is seen in boys. They have a splenomegaly. They can have lymphadenopathy, skin infiltration. The WBC count ranges around is around 33. Monocytes are there is monocytosis in the peripheral smear. Most of these patients have thrombocytopenia. They have monocytes in the peripheral blood along with precursors in the peripheral blood like myelocytes, myelocytes, and nucleated RBCs. The lab features in GMML include, like I've already mentioned, RBCs, presence of striking monocytosis, presence of myelocytes, metamyelocytes. Blast count is generally less than 2% in these cases. And when we see these cases, we are confused whether it is due to infection or whether it is because of some steroid, GCSF even. RBCs in these cases can be normocytic. Macrocytosis is generally seen in patients who have monosomy 7. Thrombocytopenia is generally seen in all patients. When you get peripheral smear with these findings, it is essential to do a bone marrow examination in infants because to rule out acute leukemia. Cytogenetic studies of CMML show that most of these patients have normal karyotype. Monosomy 7 is seen in 25% cases and other aberrations in 10%. The current classification has shifted juvenile myelomonocytic leukemia. The current WHO has shifted it from the MDS MPN type to the myeloproliferative neoplasms. Now, this is a complex disease because the mutations in the respective genes can either be germline, mostly in syndromic patients, or it can be somatic in non-syndromic patients. Also, within a genetically defined subtype, the clinical course varies on the presence of clinical risk factors. For example, age, more than 2 years, raised HbF, thrombocytopenia less than 33,000, all are associated with high risk presentation in these patients. And now risk stratification is also being studied according to the methylation classes, which I will talk about. GMML is also the other name for GMML is it is a RASopathy where there is a constitutive activation of the RAS signal transduction pathway. The canonical RAS pathway mutations that are seen in patients with GMML include the PTPN11 seen in 35%, NRAS, ARAS in 10 to 15%, neurofibromatosis 1 in 10%, and CBL in 10%. And any of these genes is present in 90% of the patients. The first gene to be identified in patients with GMML was the NF1, neurofibromatosis 1. GMML is an uncommon complication of neurofibromatosis 1. However, GMML can happen in 200 to 300 fold higher than in patients who do not have NF1, and this is due to loss of heterozygosity due to segmental uniparental disomy in large parts of chromosome 17. When you are seeing a peripheral smear that is showing picture like GMML, the clinical diagnosis, or you should call up the clinician and ask if he has examined the patient for presence of capillary spots. The requirement for diagnosing in NF1 is presence of these spots in which should be more than or equal to 6 lesions or more than 5 millimeter in size, and it is also desired at a family history, and if appropriate, inspection of mother or father's suspicious skin lesions should be done to diagnose this entity. Noonan syndrome is another case, syndromic disease, where you can get where these patients can show GMML. They have a characteristic appearance. These patients have cardiac defects, short stature, delayed psychomotor development, and they develop a GMML-like disease in infancy. And the mutation that was found to be associated with GMML-like disease in infancy in these patients was identified to be PTPN11 mutation in 50% cases. Now, whenever there is a mutation in the PTPN11, it causes constitutive activation of SHP2, and this in turn causes increased RAS pathway signal transduction. In Noonan syndrome, it was found that the mutations, there were n number of mutations that were associated. However, these mutations were germline. The PTPN mutations were of germline type, and therefore, the patients generally had a transient GMML-like or a transient myeloproliferative disease, which after a few days of follow-up or a few months of follow-up corrected on its own. This led everybody to think that probably GMML in patients who do not have Noonan syndrome could be having PTPN mutations, and this led to the identification of PTPN11 mutations in somatic as a somatic mutation. And it was then identified that somatic mutations in PT11 patients also gave rise to JMML, and these patients who had somatic mutations did not have the Noonan syndrome. It was hypothesized that PTPN11 mutations in germline configuration were mild in type and either did not manifest as JMML or had a weak gain of function effect. They caused a transient JMML-like disease, but in somatic mutations, they were strong and had a strong gain of function mutation, which led to JMML in patients without Noonan syndrome. So in germline PTPN, the patients may develop a JMML-like disease, but it regresses or it disappears after some time, in contrast to patients who have a somatic PTPN11 mutation, where the JMML is more aggressive. In addition to this, somatic NRAS and KRAS mutations were also identified in these patients. The somatic NRAS mutations were found to be heterogeneous in their subtype, with which progressed rapidly and also relapsed after hematopoietic stem cell transplantation, typically occurred in older children with high levels of HbF. However, there were some cases, patients who had an indolent course with spontaneous regression. In contrast, somatic KRAS mutations, if they were found in patients with having JMML, mostly infants had a monosomy 7 and they were aggressive at presentation, but had a low risk of relapse after allogenic transplantation. Another mutation that was identified in JMML in the germline configuration was the CBL mutation, and was due to mutations affecting the linker region or the ring finger domain in chromosome 11. Thus, both the MDS European study and the Japanese study found that of all the mutations that RAS pathway mutations that are found in children with JMML, PTPN11 is the most common, followed by NRAS and KRAS, then neurofibromatosis 1, CBL, and there were around 9% patients of JMML who did not have any of these mutations. The WHO currently defines JMML as clinical criteria that are needed for diagnosing JMML require clinical, hematological, and lab criteria, where all 5 criteria are required. Peripheral blood monocyte count more than 1, blast and promonocyte percentage in peripheral blood and bone marrow of less than 20%, clinical evidence of organ infiltration, commonly splenomegaly, no Philadelphia chromosome or BCR-ABL fusion, no KM2TA gene rearrangement. Genetic criteria, any one criterion is sufficient. Mutation in a component or a regulator of canonical RAS pathway, when one criteria is needed. Clonal somatic mutations in PTPN11, KRAS or NRAS, clonal somatic mutation, somatic or germline NF1 mutation, or loss of heterozygosity, clonal somatic or germline CBL mutation, or loss of heterozygosity of CBL. And if you do not have these canonical RAS pathway mutations, then non-canonical clonal RAS pathway pathogenic variants, even if they are seen, are sufficient to make a diagnosis, and these generally include the ALK, PDGFR, or the ROS1. Now, other criteria can also be applied in cases that do not have that one requirement of genetic criteria, or in conditions where genetic testing is not available, and must meet the following criteria in addition to the aforementioned clinical, hematologic, and lab criteria. And these include increased hemoglobin F for age, and two or equal to any 2 or more than 2 criteria. Increased hemoglobin F for age, presence of myeloid precursors, promyelocytes, myelocytes, metamyelocytes, and erythroid precursors in the peripheral smear. Thrombocytopenia with hypercellular marrow, often showing decreased number of megakaryocytes. Dysplastic features may or may not be evident, and hypersensitivity of the myeloid progenitors to GM-CSF. Now, when we are seeing of the JMML, we have to keep certain neoplastic and non-neoplastic conditions as differential diagnosis before giving a diagnosis of JMML. And the neoplastic condition that needs to be considered and excluded is infants with KM2TA rearrangements. And non-neoplastic disorders that need to be excluded include infections, Wiskott-Aldrich syndrome, leukocyte adhesion deficiency, and infantile malignant osteopetrosis, which can be ruled out by doing imaging studies where we can see increased bone density. Another another differential diagnosis in RAS positive JMML is that of RAS associated autoimmune lymphoproliferative disorders. These disorders are characterized by patients who have lymphadenopathy, massive splenomegaly, increased circulating B cells, hypergammaglobulinemia, and autoimmunity. This is a chronic non-malignant condition with persistent monocytosis and has clinical and lab features that overlap with those of JMML or CMML, including identical somatic mutations in KRAS or NRAS genes noted in peripheral blood mononuclear cells. Currently, in JMML patients, they are doing DNA methylation studies, and they have found that patients with certain genotypes have high DNA methylation, some will have intermediate methylation, and some with low. Methylation by itself is also able to prognosticate these patients. And when this methylation status was correlated with genotype, it was found that high methylation was found in patients with PTPN11 and NF1. It was found intermediate in patients, intermediate methylation group included patients with NRAS mutation, and low methylation was found in patients with favorable prognosis and correlated with CBL, Noonan or Noonan-like features. Thus, DNA methylation status can independently help in identifying patients who are at high risk, intermediate, or low risk. It is important to identify these mutations, whether they are in somatic or in germline configuration. For germline configuration, you need to do the NGS or molecular analysis in samples like hair follicles, fibroblasts in skin biopsy, buccal swab, because if these mutations are present in these tissues, they imply a germline mutation. And somatic mutations are generally done in peripheral blood and bone marrow. Now, if these mutations are found, they are treated differently. If the mutation is NRAS or KRAS, then patients are categorized as intermediate risk and high risk, taking clinical criteria also into consideration. And the intermediate risk can either be observed or given as a. Those with high risk have to go for hematopoietic stem cell transplantation. Then somatic mutations in PTPN11 and germline mutations in neurofibromatosis 1 are patients who have a very aggressive course and need to proceed straight away for hematopoietic stem cell transplantation. Germline CBL syndrome generally shows spontaneous regression and patients can be observed. And so is the case in patients who have PTPN11 in Noonan syndrome patients, where you can observe because the transient JMML-like disease will regress. Here are some of our publications from the department on the same topics. This is one of our publication on case series of clinical and hematological profile of juvenile myelomonocytic leukemia done by Dr. Anurag Saha, where we studied 6 cases of JMML over a period of 6 years. And when we did cytogenomic profiling by NGS, we found that in one case, we got a PTPN somatic mutation. And the patient was, after the diagnosis, patient was, I think, lost to follow-up. We didn't know what happened regarding the treatment. And in one case, the NGS was showing negative for mutations, where we then applied the other minor criteria for diagnosing this case. Another study that we did was an assessment of the 3 popular prognostic scoring systems for chronic myelomonocytic leukemia in an Indian context. And here again, we found in our study that patients with the dysplastic, when we categorize these patients, we had more of patients who are the proliferative type of CMML than the dysplastic CMML. And when we compare the 3 scores that are used for classifying this disease, the CMML's prognostic specific score, the MD Anderson score, or the Mayo Clinic score, we found that when mutational analysis is not possible, especially in a government setup like us, not all patients get NGS studies done. We can use any of these 3 scores and they are quite comparable, and patients were they were all comparable, and in 4 of our cases, of the 23 cases, there was AML transformation. To conclude, diagnosis of monocytic malignancies are challenging. It needs assessment of morphology in peripheral blood and bone marrow. One has to be sure regarding monoblasts, promonocytes, and monocytes, because the diagnosis is based on that. Clinical history is needed, because in acute leukemias of myelomonocytic type, the history will be short, whereas in CMML, there is a prolonged history. We need to see the ultrasound for splenomegaly in cases of CMML, if it is of a proliferative type, and dysplasia if it is of the MDS type. Flow cytometry with recent insights in monocytic partitioning seems to be promising. Cytogenetic and mutational analysis are now essential for diagnosis as well as prognosis, and treatment protocols need incorporation of both clinical and molecular test results. This is our department with DM oncopathology residents. The lady in the center is our HOD, and these are all our enthusiastic residents. Whenever they get posted to the hematology section, within 2 or 3 days, when they begin to see peripheral smears, they call me and ask me to identify a cell and ask me whether is it an immature monocyte or a pro-monocyte. And then the story of this challenging diagnosis begins every time a new set of residents come. Thank you for your kind attention.
Thank you so much, ma'am, for that excellent webinar, excellent lecture. You were awesome, fantastic, ma'am. Thank you so much once again, ma'am. Now we have our colleagues over here who are going to discuss you and have a question answer session. I request all our discussants to please put the raise hand signs so that we can start our question answer session.
Can I ask one question, please?
Please, sir, please go ahead.
Yeah. First of all, many compliments to Dr. Sauni for an excellent presentation, on CMML and the acute myeloid leukemias, particularly with the monocytic components. Browsing through the literature, I found that about 30% of CMML patients, have either an antecedent or coexistent, history of autoimmune diseases like rheumatoid arthritis. And when we talk about the partitioning, and the criteria of partitioning the monocytes based on the CD14 and 16 positivity or negativity, it is a general knowledge that the CMML patients have M01 type, that is
Yes.
right, and
Yes.
that's the classical monocytes. Now, what happens is, in these conditions, these autoimmune conditions, it is very frequently found that there is a preponderance of type 2, that is the intermediate type of the monocytes, which are more seen. So it somehow the other throws that particular majority of CD01 into imbalance and creates a lot of confusion in interpretation. So have you found such a thing in your clinical practice, madam?
Sir, for CMML cases, firstly, they are very rare. And when we try to get it done in one of our cases of CMML, CD14 and 16, we were not getting the cut of 94% in the M0 type. And we too were confused. And we asked for the file of the patient because morphologically and other criteria were looking like CMML. But the flow cytometry was not supporting what has been published regarding more than 94%. And on history, we also found that the patient was having some inflammatory condition. And we presume that probably this partitioning is not as what is needed because this patient is having an inflammatory condition. But we could not validate this because these cases are so rare that we hardly get as many cases to do flow cytometry to validate this point of more than 94% classical monocytes.
Another article I got, continuing this discussion, that we usually rely on the study by Salimoglu. That's what you also mentioned, that it is the majority CD01, M01 type of monocytes, which have a more sensitivity. That particular study had about 91% and specificity of 25%. But another study stated that when you look at the decreased numbers, not the increased numbers, but decreased numbers of M03 fraction, which would be less than say 1.13% in peripheral blood or 2.42 less than that in bone marrow, that has a better sensitivity and specificity in diagnosing CMML. I mean, sensitivity would be increasing to 94%. Now, have you come across such a thing, or do you apply such criteria in
No,
cases
sir.
of doubt?
No, sir, I have not read this article, but if it is like this, we will look into this. So we
And
hardly,
yeah,
yes,
sure. Please go ahead. I'm sorry.
we hardly get as many cases, and so flow cytometry we're not doing as much as to validate these points. We're not getting as many
I'm
cases.
sure GCRI, has the facility for.
We have facility for flow cytometry, but sir, like this M03, we have not done.
Okay. Another thing is, I'm sure you must be advocating, at least whenever you give a report of CMML, the test for TAT2 and ASXL1. I mean, are they routinely carried out? Because they tell us a lot about the prognosis. That the TAT2 positivity and ASXL1 negativity would mean a favorable course. So do you
Sir,
ask the clinicians to get it done? Or?
Sir, if the patient is affording, these patients are, we are currently not doing NGS studies in our setup. These patients are sent to private labs for doing NGS testing currently. But if their patients are affording, these mutations are doing, a myeloid gene panel is being done, and AXL1, JAK2 mutations, if present, are taken into consideration.
And a very good point was raised by you, in considering or differentiating pro-monocytes from the monoblasts, when counting them in either the peripheral blood or bone marrow. And usually people club them together. Is it
Yes.
Is it that we club them to arrive at that percentage?
Sir, the books and the WHO say that the pro-monocytes are equivalent to blasts, and so they should be clubbed together in the blast count. So pro-monocytes are equivalent to blasts in monocytic leukemias.
Now, another thing, because of there's a lot of tuberculosis, infection in the community, in particular in our country, and many a times it associated with monocytosis. Have you found any overdiagnosis of CMML in such cases?
Sir, most of the
Sometimes,
times,
the patients would be referred to you, the Cancer Institute, from the periphery or from some other pathology labs or some other private clinicians. A suspect, there is a suspicion, very strong suspicion of CMML. It doesn't turn out to be so. But have you found such a thing?
yes, sir. It is sometimes the cases are referred by the clinicians with a provisional diagnosis of CMML, and when we see their bone marrow biopsy, we find granulomas. When we go detail into their history, we get to know they have been having prolonged fever, and sometimes the history of they taking AKT over a few years back also is obtained. So we have cases where they're thought of as CMML, but when we do a bone marrow biopsy, we get granulomas, and then we realize that these are actually cases due tuberculosis cases and not due to CMML.
Likewise, any patients with beta thalassemia major, when they have more fetal hemoglobin and the organomegaly, the splenomegaly, and they are very prone to different types of infections, and many a times you do find monocytosis, in thalassemic patients. So do they cause any problems with the diagnosis, because both the conditions are totally different?
The beta thalassemia major are generally young patients,
But
and
yeah.
GMML.
But a 2-year-old child, suppose, comes with splenomegaly, fetal hemoglobin very high, as regards, with respect to the age, and the classical symptom, of course, they won't be having thrombocytopenia. Usually, that would be the thing, in CMML.
Yes, sir.
And of course, you will be doing other tests also. Of course, all these mutations. I'm sure all these RAS mutations are done at GCRI. I'm sure they are done.
So patients are referred outside, and those who can get done, like in my publication, 2 cases had got NGS done. One was PTPN11 positive, and one was negative for all mutations. So there are cases where NGS is done, but those who cannot do, we do cytogenetics to see for clonality. And regarding your thalassemia major question, sir, before we give a diagnosis of GMML, which is such a rare disease, we generally work up the case which is showing in a large number of nucleated RBCs in the peripheral smear. for
That's true.
HB
I mean,
electrophoresis or
it
HPLC.
should not cause any
Yes, sir.
problems. It should not
we-
cause any
For
problems.
young patients, we always go for HPLC or HB electrophoresis before proceeding for a malignant diagnosis.
I will surely read, that paper of yours, which you have published.
Thank you, sir.
So thank you once again. It was a very nice presentation. All the points were covered very nicely.
Thank you, sir.
Thank you very much. All the best wishes.
Thank you, sir.
Thank you.
Thank you, Dr. Nilesh, sir. Dr. Rama, your question, please.
Good evening, ma'am, and to all here. I have two questions, ma'am. So in CMML, there is increased abnormal monocytes in peripheral blood. And how can you differentiate that from the AMML, where it shows similar kind of monocytes, especially in the acute monocytic leukemia or in AML M4, where the blast percentage count right now is not required up to 20%, especially in case of recurrent genetic abnormalities. So in these cases, how we are going to differentiate between CMML and AML with recurrent genetic abnormalities? Kindly say.
In AMML and CMML, firstly, we look for monoblasts because you will not get any monoblasts in the CMML, but in acute monoblastic leukemias, we will expect monoblasts in the peripheral smear. Promonocytes also, with expertise, we are able to identify and differentiate from immature monocytes.
Yeah,
and history is very forthcoming because in patients with acute leukemia, if they are getting referred, the history is for a very short period of time. And we do cytochemistry to see for MP or SB staining. And if we even then are feeling little doubtful, we examine the bone marrow in detail for blasts and even send the sample for flow cytometry, or if do an IHC for CD34 to identify whether it is present or not, or IPT.
Yeah,
for
ma'am.
differentiating.
Acute monoblastic leukemia is okay, but acute monocytic leukemia, where most of them are mature monocytes in the peripheral smear. So in that case, how we need to proceed further?
In acute monocyte, most of the cells in the blood are not mature monocytes. They're basically more of promonocytes, like what used to be called AML M5B. So in these cases, we see for downregulation of CD117 and increased expression of HLA-DR. And for CMML, they say that you should look for other aberrancies like CD2, CD56, which are not seen in blasts of monoblast or promonocytes in acute leukemias. So CD56 aberrancies, decreased expression of HLA-DR, decreased expression of CD33, CD2 aberrant expression. These are more commonly seen in mature leukemias that are happening in patients of CMML or CMML transforming to leukemia rather than acute monocytic leukemia.
Okay, ma'am. Nowadays, these spliceosome mutations and ASXL1, all DNMT3, all these TET2 even can also come in AMLs. So molecularly, how we are going to differentiate this?
They say that TET2, SRSF2, and molecularly, you cannot make any diagnosis just based on molecular profiling. You have to put the total. That is why you see the criteria will have 4 or 5 points where they will say consider peripheral blood monocytosis, and then you consider where the patient, what is the clinical condition of the patient, rule out BCR ABL, and then you consider the molecular mutations. And if your absolute monocyte count is very high and they look like mature monocytes, then these mutations will go in favor of CMML rather than AML. So based just on molecular profiling, the case has to be seen in total clinically, then based on morphology of the peripheral smear, and then we have to see the mutations, not the other way around.
Okay, ma'am. Can I ask one more question?
Yeah, sure.
Yeah. Is there any risk of AML transformation in the CMML? If so, are there any indicators or any clinical or molecular indicators to state that there is a progression risk in this patient?
Firstly, when on follow-up, you will a case of CMML1 may transform to CMML2, which means rising blast counts, or CMML2 will start showing more on follow-up, the blast count begins to increase. And so molecular markers, they say if a case is progressing to acute leukemia, you can get molecular markers like SET or RUNX1, And these in a background of CMML mutations can imply that the case is progressing to acute leukemia. Set BP1 or RUNX mutations in a background of CMML type of mutations will suggest that this case is possibly transforming from, along with an increasing blast count, will imply that the case is transforming. And in a BMBX, you can even do CD34, CD11 staining to see whether there is an increase in the blast counts in the biopsy. Or if possible, you can even send that same case for IPT.
Yeah, is that true with NPM1 mutation also, ma'am?
NPM mutation
CMML
is
with
present in
NPM.
CMML. If you're thinking of a case to be CMML and you get an NPM mutation, then it needs a revision of diagnosis to acute leukemia, because even NPM associated leukemia show monocytic proliferation. So they say that if you're getting, you're thinking of CMML and you're getting NPM mutation, then the diagnosis needs to be revised to acute myelomonocytic leukemia and treated like acute leukemia.
Okay, ma'am. Thank you, ma'am.
Welcome.
Thank you, Dr. Rama. Dr. Miyat Malashwe, your question, please.
Hello. So thank you so much, Doctor, for your excellent presentation. As I want to know is there any cutoff value for the dysplasia in the myelodysplastic CMML?
Madam,
Yeah. Yes, I want to know is there any cutoff value for the dysplasia in the myeloid MD-CMML?
Madam, it says you have to see for, you have to do a differential in the bone marrow of at least 500 cells, and you should get dysplasia of greater than or equal to 10% in any of the 3 myeloid lineages. And in megakaryocytic dysplasia, you need to see at least 30 dysplastic megakaryocytes. These are the same criteria which are followed for MDS also. For
Yes.
making a diagnosis of MDS, is the same applies for MDS type of CMML.
Yes. So it
More
cannot
than
be
or equal to 10% in any of the 3 lineages.
Yeah, so I'm wondering that is there quite difficult to differentiate between the MDS IB increased plus and the MD-CMML.
And then you have to take the peripheral blood monocytic count, absolute monocytic count into consideration.
Yes, thank you so much.
Thank you, Dr. Sway. Dr. Geeta Vidyadharan, your question, please.
Hi, ma'am. Thank you so much for an excellent presentation. I had this query that, ma'am, in clonal monocytosis of undetermined significance, is there a duration mentioned? Because as the definition, we don't have any, we have excluded reactive conditions. We have excluded myeloid neoplasm. We have excluded even dysplasia. So is there any duration, like how can we entertain this diagnosis of clonal monocytosis of undetermined significance?
The paper says that clonal monocytosis of undetermined significance, you should have any of somatic myeloid malignancy. And if this monocytic somatic mutation is the one which you get in CMML, like TET2, AXSL1 or SRSF2, then the chances are that these cases need follow-up because there are chances that they will transform in future to CMML. But if there is any other mutation other than that which is seen in CMML, you have to look for the variant allele frequency. And if it is not very high, less than 10%, then you can just keep on follow-up, but they have not mentioned for how long you keep following them up. But definitely those that are having that CMML type of mutations, they need to be followed up more regularly because they can transform to CMML.
Okay, ma'am. So that means that if we have a suspicion, then definitely go for the genetic studies.
That is what the one paper was saying.
Ma'am.
That is what one paper was saying. When you are getting no answer for the persistent monocytosis, in one paper I was saying, they were not able to diagnose CMML according to the criteria defined. And they sent it for mutational analysis according to targeted gene sequencing. They found at least one mutation in some of these samples, and they felt that these need follow. And they behave like CMML. They have worse prognosis than unmutated cases. So persistent monocytosis, one can refer patients for NGS panel analysis if the clinical suspicion for clonality is there.
Okay. Ma'am, I have one more query that we've been using this terminology of abnormal monocytes also when we discuss CMML. So many times students have this confusion that the blasts and monocytes, and then the next one is abnormal monocytes. So could you elaborate on that also?
Madam, that table which I had shown, that the third column was of immature monocyte. The articles are calling this immature monocyte as abnormal monocytes.
As abnormal.
Yeah.
Okay, so that is more in favor of a CMML, ma'am?
Yeah. Yes, that is more in favor of a mature neoplasm.
Thank you.
Thank you, Dr. Geeta. Dr. Savitri, your question, please.
Hello, excellent presentation. Am I audible, sir?
Yes, yes, ma'am. Yes.
Yeah, excellent presentation, madam. You have not left anything for me to ask. I'm working in a pediatric institute. I just want to ask one small question. In 5-part analyzer, mostly we get monocytes high because ours is a pediatric institute, and around out of 120 or 180 samples, 30 samples would be from less than 2 years of age group. So they show most of the time monocyte high. So if PS has been asked, then we make smear and try to exclude that variant lymphocyte because of many viral infection which may be counted in the monocyte zone. So that, okay, we can sort them out. Remaining, if patient clinician is suspecting that KFL spot is there or NF1 is there, then of course PS and marrow findings are matching. They go ahead with the cytogenetic workup and assign the diagnosis of JMML. But many a times it happens, some viral infection, we may not have the history. Patient may have HSM, they may have NRBCs, myelocyte, and also monocytes. In that case, what minimum investigation we can do for the time being to follow up and then go for higher workup to establish the diagnosis?
Madam, we can do HbF levels. Then
Okay,
we should also look for, because in JMML, most of the time patients will have thrombocytopenia. Then splenomegaly, if it is significant. And these are the things which one, and keep the patient on follow-up, like for these clonality needs to be proven, but in JMML, 65% cases are having normal karyotype.
Yeah,
So
that will also
if you are getting a history of infection, if the infection, after controlling the infection, the monocytosis is persisting and you are getting immature myeloid precursors despite treatment of the infection, then and it is persisting for a long time. We have got cases where the child has been referred to many hospitals for 4 or 5 months, and even then the pediatrician is unable to understand what is the reason for the monocytosis. Then prolonged monocytosis, or that is persisting for a long period of time, needs to be now evaluated for clonality. And in that case, molecular workup needs to be done. And 90% of these patients will have a rasopathy, any one of the mutation.
Okay, so basic minimum with a good PS and BMA, basic we can get HbF level done and keep in follow for at least 10-15 days. And then next visit, of course, we can assess and go ahead with the further testing.
Ma'am, there are cases which go for clonality after going to hospitals for 4 or 5, 6 months because they feel one pediatrician is unable to sort out their problem. They go to a different one. But when we review their file and see that the monocytosis is not coming down despite 4 or 5 months duration, then these cases need to be taken up for mutational analysis if the karyotype is normal.
Okay, so lesson taken from your talk should be that monocytosis in any case should not be left unnoticed. Either we have to this all chronic infections or torch and viral, because they may be having a neonatal period, and then presentation would be very much close mimicker of JMML, that
yes, ma'am.
CMV comes like that. Okay, another small question is CMML with very extreme eosinophilia at times mimic like that of CML. So in that case, we have to resort to only this Philadelphia chromosome, or anything else we can do.
And Philadelphia chromosome is needed. The P190 transcript in CML is associated with monocytosis. Apart from them, these tyrosine kinase mutations, that is PDGFR beta, translocation 512, which can be picked up on a normal karyotypic analysis, should also be done, because if PDGFR beta comes positive, then they are treated with imatinib. Their treatment profile will become different from CMML.
Better also. Yeah. Okay. Thank you, ma'am. Thank you so much. An excellent presentation once
Thank you,
again.
ma'am.
Yeah.
Thank you.
Thank you, Dr. Savitri. Dr. Akshay Mandla, your question, please.
Thank you, sir. And thank you, ma'am, for the wonderful presentation. It was a really practical one. I have one query. Part of it you have already covered. Basically, we are facing one problem, that patient coming to us with acute leukemia are already having or have already got some alternative medication. So the problem we are facing is differentiating between CMML2 versus partially treated acute leukemia, in whom blast counts have come down between to less than 20%, and we are having many dysplastic monocytes.
Patient partially treated acute leukemia, could you just tell me how has he been treated? With steroids?
Alternative medications, basically. Every time we are getting a history of that patient has taken some Ayurvedic medication or some homeopathic treatment. So probably steroids.
In acute leukemia with monocytosis, you need to get those CBF, MYH mutation analysis like translocation 16, inversion 16. These are mutations that are associated with acute myeloid leukemia and not with CMML. So CMML has a karyotypically is different from AMML. So one thing that you can do is to do a cytogenetic study. And in chronic history should be in favor of CMML, acute history is in favor of AML.
And also flow will help.
Yeah, flow will help, but I don't know. Yeah, CD34, 117, if they're coming, it will sort out whether these are in CMML blasts. 34, 117 expression is not very commonly expressed, whereas in case of acute leukemia, you generally get CD34 and 117 positivity.
Okay, so basically the answer is going to come from molecular only.
Molecular and cytogenetic analysis.
Okay,
thank you.
Also, CD14 will not come in the AMML cases, because 14 positivity, and mostly they are mature monocytes which we see in the CMML, and in AML it will not be the case. We will get 64 along with decreased expression of 14, something like that in flow, with blast markers like CD34.
When it goes to pro-monocytic stage and mature monocytic stage in acute leukemia also, you can get CD14. I showed in the monocytic maturation pattern, 64, then 14 begins to come in the pro-monocytic stage, and mature will have 64, 14 along with CD35 and CD300. So 14 you can get in both.
Okay,
so
basically
the partitioning it was
combination of
based on CD14 and CD16 and CMML.
Okay, basically the combination of immature blast markers and mature markers, it should be more towards AML, like that, ma'am.
Yeah, and in CMML they say you get many of the cases show CD56 aberrancy, CD2 aberrancy. So these cases are more in favor of CMML than CD300. If you're doing these are mature monocytes which you can get in CMML.
Okay.
Any other question, Dr. Akshay?
No, that's it, sir.
Dr. Rama, ma'am, you have got any other question?
Yes, yes, sir. I want to ask, in JMML, we have both somatic mutations and genetic mutations. That is, their recognition is very important in the prognostication of the patient as well. So how we are going to say this patient is having genetic mutation rather than somatic mutation? So how we test and where we need to test?
For genetic or germline mutation, you will get it in all tissues. So it is recommended that when you're suspecting, firstly, genetic mutations are generally seen in syndromic patients. Germline mutations are generally seen in patients who are having some syndrome. Apart from that, tissues that can be used for DNA extraction are hair follicles, buccal swab, fibroblasts from skin biopsy. And in somatic mutations, the DNA is extracted from blood and or bone marrow. So this is one way of differentiating. If you're getting it in these tissues, then it is a germline mutation. And if you're not getting it, if you're getting in the peripheral blood and bone marrow, then it is somatic mutation. Just in case a lab is not doing these other tissues, then you need to just wait and watch and see how the patient behaves. Because these patients of germline mutations, especially if it is not neurofibromatosis 1, will regress over a period of time.
Okay, ma'am. And you have told about JAK2 mutations can also be present in CMML, right?
Yeah.
So how can we differentiate the JAK2 from MPMs and the CMML having the JAK2 mutation?
CMML with fibrosis generally is shown to have JAK2, and here they say, firstly you see the bone marrow biopsy, because CMML biopsy megakaryocytes will be different from what you see in myelofibrosis. Megakaryocytic clustering, abnormal localization, paratrabecular location, all will go in favor of myelofibrosis. And JAK2 variant allele frequency, if it is very high, it will go in favor of MPN. And if it is variant allele frequency is not very high, then it is in favor of CMML.
Okay, ma'am. Thank you.
Thank you, Dr. Rama. Dr. Deepak, you have got a question? Dr. Deepak, you have any question?
Yeah, hello, ma'am. Thanks a lot for elaborative and very informative speech that you have given. Can you hear me, sir?
Yes.
Yeah. So I think there are no questions. Everything has been covered here. And I think the take-home message is there is conglomeration of, we have to conglomerate all these morphological, flow cytometric findings and molecular and cytogenetics and especially clinical features and close hemat follow to come into conclusion.
Yes.
Of course, flow cytometry, as you told, we get rare cases are rare, and sometimes patients are not affordable for flow, and clinicians they send it directly for molecular studies apart from morphology. So there can be some fluctuation because of associated inflammations and autoimmune disorders. And I think I've come across one case recently where the patient, elderly individual, was having he had a case of Rosai-Dorfman disease, lymph node. So it was resected, and after a few months, so he was diagnosed with chronic myelomonocytic leukemia outside with NRAS mutation. So he was on follow-up with treatment, and recently had some 3 to 4% abnormal monocytes on peripheral smear. So at the same time, he landed up with pericardial effusion with thickening. Biopsy was done, and it turned out as myeloid sarcoma. So we asked for bone marrow, but because of he was in CI cardiac care unit, after a week they did bone marrow, and then turned out as full-blown acute monocytic leukemia. So I think there can be some clonal association between these solid malignancies and the chronic myelomonocytic leukemia. So any experience from your side, ma'am, regarding this?
They say that cases of CMML in about 20 to 30% of the cases can transform to acute leukemia. So, and most of the times these are acute myelomonocytic leukemias only. So probably there is an it could have progressed, the disease could have progressed and transformed to acute leukemia, or it could have presented as a myeloid sarcoma. I presume that way.
So I recently read an article showing a clonal association between Rosai-Dorfman disease and chronic myelomonocytic leukemia, especially in NRAS mutations. So,
okay. It is possible. It is possible that the two are associated.
Thanks a lot, ma'am. Thanks a lot.
Welcome.
Thank you, Dr. Deepak. Dr. Geeta, Vidyadharan, you have got a question? Dr. Geeta, yeah. You have got any other question, Dr. Geeta?
No, sir. No.
Okay. Dr. Savitri, ma'am, do you have a question? I think no other question. Dr. Savitri, you have got a question? Fine. So I think if no other question, well, that was a wonderful question answer session, ma'am. And what a wonderful lecture. You were really fantastic and awesome.
Thank you.
We learned a lot from you today. Every slide was very crystal clear, and it was worth learning from you, ma'am. Thank you so much for a wonderful talk, for a wonderful question answer session on this Saturday evening. It really helped us. It was very much a knowledgeable session. Thank you so much for being with us, ma'am.
Thank you, sir. Thank you.
Thank you, ma'am.
I now hand over to Zydus, Mr. Sumit Madan, for the final vote of thanks.
Thank you, Dr. Jyoti Sahani, for sparing your valuable time. It was a lucid presentation and you covered many important points, and we have many key takeaways from this wonderful, excellent presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank Dr. Amit Khurana, all the discussants and participants who have joined us for this live webinar. Dr. Amit navigated the entire webinar in a highly proficient manner. Last but not the least, this series of webinars is possible only because of continuous support from Perfect Square team. So thank you to them as well. Thank you, everybody, and have a wonderful weekend.
Thank you.
Thank you.
Thank you. Bye.
Thank you, ma'am, and thank you all.
Thank you. Bye.
Bye-bye.